I get this comment quite a bit when I talk about my role as a clinical nurse unit manager in emergency, and I say that I work as the person in charge of emergency. There's always people in the comments that are like, you're not in charge of emergency, the doctors are in charge of emergency, you're in charge of the doctors. And then these accounts like this I can tell you right now is not a healthcare worker and they're not a nurse. They're not a critical care nurse, I promise you. It's almost always someone that has an aversion towards nurses, and that aversion often comes towards an aversion towards women that they just don't like for whatever reason, and they want to comment something like this and appear as if they know what they're talking about to get other people on the bandwagon to go against me. Now, in the video, all I'm talking about is that my role is quite stressful and that I'm in charge of ED, which if you work in healthcare is correct. And any doctor that works in emergency will tell you the same thing. And I'm not even saying that to be cocky. They will tell you the same thing, that the navigator or the nurse in charge is the one that runs the show in emergency. We're not just running the nurses, we're running the show of emergency. The clinical NUM is essentially the captain of the ship, okay? On the first level, we allocate nurses to everywhere that they need to go. We need to understand their skill level, we need to know all of the nurses. Then we need to make sure that they're working alongside people that are safe to work with in terms of skill, okay? So you can't have like all juniors in one area and all the seniors in another area, because that means one area will be less safe and one area will be more safe, and also it's just not fair to the team. So you're distributing that across the department, okay? Then you're making sure that every nurse is doing their job properly. So you're going in, you're checking the patient's notes, you're going in rounding, you're checking in with them. Do you need help with anything? Do you need a hand? Like, you're constantly doing rounding of the department to visualize patients, to check in with your nurses. That's on the basic level, okay? Basic level is staffing and managing nurses. Then there comes bed flow, which falls to me to manage, not the doctors, me. Now that doesn't mean if a doctor says to me, hey Ellie, I really need a bed for this patient in the waiting room, where can I go? That's how the conversation goes. They'll go, talk to Ellie, work on a bed. They come to me, I say, okay, I don't have any beds at the moment, so what do I do about that? I don't say, doctor, please make a bed. That's not how it works. I'm the one that has to come up with a way and a plan to get a bed for unwell patients. So if I have a floor filled with admitting patients, I'm constantly on the phone to the bed flow manager of the hospital saying, hey, all these patients have been here for X amount of hours and I don't have any room for new patients coming into emergency and I need them to be seen. Or my resus bay is full and I can't step them down onto the acute floor. What are we going to do? We're going to open up a bed in ICU for these patients. What are we going to do? So I'm constantly on the phone trying to organize that, right? At the same time, ambulances are coming in. They also have to offload. They also have to get into a bed space or into the waiting room after they've been triaged. So I need to know what category they are and how suitable they are to go to the waiting room or into a bed. So then ambulance also gets involved. So, they'll be on the phone to the bed manager who's on the phone to me and saying, what's the plan? How come we can't offload? All right. And then the doctors will say to me, what's the plan? I'll go, okay, well, at the moment, we only have we have a lot of demand for short stay, not a lot of demand in fast track. I'm going to pull a fast track nurse into short stay to open beds in short stay so that I can send people into short stay, hoping that they get discharged, open up some beds on the floor so we can see more patients. Okay? Another element of that, if we have an unwell mental health patient that needs to have an ART called because they're in an acute psychosis, I'm the team leader. So I go pulled away to that. I go over to that. I'm the team leader for that. I help with managing the team for this ART call, which is essentially like an aggressive response team to make sure that the staff is safe, the patient is safe, everyone is safe. So I'm the team leader because I'm the most senior nurse in the department. Okay, if a resus comes in, all of my resources go into resus to save that patient. If they're in cardiac arrest, whatever they're in, I have to go in, team lead the nursing staff, and step down when it's all sorted. And then go back to the floor, make sure the floor is safe, check in with all the nurses, check in with the doctors, make sure the people are going to the ward, all of that. It's not a simple thing. If something goes wrong, say that there's downtime. So computers go down. It's called downtime. We can't access the computers. It's nursing led. It's nursing led. The doctors will look to the nurses and go, where's all the paperwork? What do we do? How do we run downtime? It is nursing led. This does not mean that things are not collaborative with the doctors. It 100% is. Obviously, they are making the diagnoses and the clinical decisions, and there's a lot of respect there, but in terms of the actual running of the department, it is the nurse in charge. Okay? So I'd really appreciate it if people try not to degrade the work that I'm doing, because I promise you, I'm not coming on here and saying that it's a stressful job and that I'm in charge of emergency just to say that. It's just that it's the truth.